And welcome to the Dr. Bob Show. Hey, have you looked at your neck? Do you have a little lump on your neck on the left side or the right side? Are they tender? How big are they? How long have they been there? What do they do to? What about the middle of your neck, around where the Adam's apple is? You see an enlargement there? Do you see one side that's bigger than the other? Could that be a nodule in your thyroid gland? We'll be talking about all those things on this show. My guest is Dr. Mark Overholt. He's an otorhinolaryngologist. Those are a lot of words. Simply means he's an ear, nose, and throat, including the thyroid and the neck. And he'll be giving us some insight to if we feel a lump or a bump, and it may be thyroid, are there new tests that can help us decide whether or not we may not need surgery? It'll be a lot of information for you. I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show as we learn about the thyroid gland and what problems that can be prevented or that they can cause. We're talking with Dr. Mark Overholt, board certified otorhinolaryngologist. I love the word, it's so long. Ear, nose, and throat physician, works with the neck and little lumps and bumps in the neck. And that's what we're going to be talking about. Mark, welcome to the Dr. Bob Show.
Thanks for having me.
Can you look at the neck and see enlargement frequently?
Sure. People come to ear, nose, and throat doctors all the time with little lumps and bumps in the head and neck that bother them. And
they say, what's this?
Yeah.
What's in the back of their mind?
Pretty common in our world.
Yeah, it really is, isn't it? And so do they find it just by feeling their neck or just looking in the mirror or just happenstance?
Well, most often people find them because they just feel them in their neck. But, with imaging studies now, and we do more surveillance with CT scans and ultrasounds, we pick up a lot of incidental lumps and bumps too that people can't feel, and those people come to us as well.
So when a patient has a lump or a bump in their neck, I would think the first thoughts were, I wonder what caused that, and I wonder if it's anything wrong and anything bad. I wonder how long it's been there. I wonder if it's going to go away or if it's going to get bigger. I mean, lots of questions start coming up.
It's an anxiety-provoking moment for people. It gets them scared, and they're worried. They think the worst always, and most often it's not. But certainly, as ear, nose, and throat doctor, we do our best to try to allay people's fears and take care of it. And most of the time, things end up well.
So, how do you approach a lump or a bump in the side of the neck or in the midline? You can take them both.
So it depends on how the patient comes to you. Most of the time they'll come with a known mass and that they've felt, and very often their astute internal medicine physician has done some sort of imaging study that documents the size and location. So when they come to us, we sort of have an idea of what the mass might be and what further diagnostic evaluation is necessary. And
when you say imaging study, what do you mean? X-ray?
CT scans or ultrasounds of the neck, either one.
So they frequently come with information that will help you in your initial evaluation of that lump or that bump.
Yeah, it focuses our attention on where might this be coming from, and then we pursue the diagnostic pathway to figure it out.
So the thyroid is located where, on the side or right in the midline?
So we're talking about lumps and bumps, but a lot of lumps and bumps are low in the midline of the neck, and that's where the thyroid lives. It's a butterfly-shaped structure that drapes over the trachea, over the windpipe, down low in the neck, just above the collarbone. And the thyroid gland can have bumps. In fact, 5 to 8% of people in the U.S. will have a bump in their thyroid that's of no clinical significance. So it's not uncommon that we see people that have lumps and bumps, and there's nothing to worry about.
Is it easy to feel?
It can be. It depends on the person's physique.
Neck size.
Yeah, real thick necks are sometimes hard to feel, and long, thin, as we say, aquiline necks are very easy to palpate. But patients will very often come and say, "I've noticed a mass in my thyroid." And we have smart patients in this world that come to us with good education that they've gotten from the internet, and so they have a preconceived notion of what it might be, and it's our job to define it more.
So if there's a lump in the thyroid, a little butterfly-shaped gland, is it more common one side than the other, or is it usually both sides? Or
The thyroid nodules don't have a side predilection. They don't choose left or right. They tend to be more common in women. We see them mostly in middle age, and for the most part, they're benign. So when we see people who have a thyroid nodule, the first thing we want to do as a head and neck surgeon is to get an ultrasound, because it's the tool that helps us define the thyroid nodule the best. It tells us characteristics about that nodule that help us decide, is this something that's benign and really doesn't need any further follow-up, or maybe it just needs another ultrasound in a year, or it has some criteria on the ultrasound that say, this needs a biopsy.
so is that easy to define the borders and their character with an ultrasound?
Yeah, ultrasounds are very, very sensitive these days, and the American College of Radiology has come up with some ways that we have language that we use to talk about thyroid nodules. Is the border of the nodule irregular, or is it smooth? Is it wider than tall or taller than wide? Does it have little calcium dots in the nodule that
And you can see all that with ultrasound.
Yeah, the ultrasounds are great, and all those little features that I talked about fit into a scheme that allows us to grade thyroid nodules, and based on that grading and the size of the nodule, we determine whether or not a biopsy is needed. If you need a biopsy, we use ultrasound again to guide little skinny fine needles into the thyroid nodule, aspirate some of those cells out. We can put them on a slide and look at them under a microscope, and our pathologists are excellent at being able to tell us, does this look benign or malignant? And in the case that there's kind of a question, it's still a gray zone area, then we're getting better at using genetics and RNA. And
What will that tell you?
that helps us stratify the gray zone areas into low risk groups where people don't need surgery, or a high risk group where they're going to need some surgical removal. We've gotten so good with ultrasounds, and we're picking up so many nodules, that over the past few decades, the trend has been towards more thyroid surgery for benign disease. And in retrospect, we've had to sort of examine and ask ourselves, are we doing more surgery than we needed to be doing? And so on the heels of that, the genetic testing has sort of grown, and our knowledge of all that has gotten better, and we'll be able to use specific genetic tests to determine, is this patient one that we can say, even though it's kind of a gray zone nodule, it doesn't require surgery. Let's table this for a while, look at it again in 6 months or a year with an ultrasound. Or on the other side of the coin, hey, this one sort of stratifies into a more higher risk group, and we need to go ahead and get this thing out. And so we're trying to be smarter. We're trying to operate less, because we know that many thyroid nodules are benign, if not most, and we're trying to do less surgery in those areas. So your doctors that do head and neck surgery are well trained in all these things, and use all this data to come to a careful decision for you, the patient.
And I think that's what's so important, is that you take data, analyze the data, make decisions, and see if you're going to need it removed or not. Now, when you remove a nodule, is that difficult? And what I'm thinking about is an illness called Hashimoto's disease, struma lymphomatosa. I just remember that long name. But it's a thyroid gland that's full and thick and a little firmer and apparently sticky, and so can
You're
cause
exactly
trouble.
right. So there are, in people who have non-malignant disease, not cancer, the surgery can still be complicated. And in Hashimoto's disease, which is an autoimmune, the body's reacting against its own tissue, inflammatory condition, those glands can be very sticky and firm, and They can attach to important structures that we'll talk about in a second, and it can make the surgery more complicated. Graves' disease patients who have very hyperactive thyroids, the people that you see that have the bulging eyes as a result of the thyroid disease can be more complicated surgery in benign disease. And so if you go to have thyroid surgery, you need to go to somebody who does a lot of it. The general bar is 50 cases per year, where we say at that level you've achieved competency as a surgeon. You're doing enough in your practice to keep it regular, and I think most people who are doing that much are committed to the academic side of the thyroid surgery.
When you do thyroid surgery or surgery in the neck or looking for a lump or a bump or a nodule, is there a lot of investigation? That's what we're going to be talking about when we come back. When you get in there, what do you do? Do you have to wiggle around, or is it pretty well set, or every patient is different and has to be treated differently? We're talking with Dr. Mark Overholt, board-certified otorhinolaryngologist, ear, nose, and throat. We've talked about lumps and bumps in the neck. We've gone down toward the thyroid, and we're talking about thyroid nodules, whether they're including the whole thyroid or just a little bump. And we've talked about ultrasound, which gives us, the surgeons, so much knowledge as to what to expect. Now, when you get in the neck and you've opened up the neck, what do you do? What's it feel like? What's it look like? That's pretty exciting to me. I've never done that.
Yeah, the thyroid gland is reddish brown, and as I said, it drapes around the trachea, and it is small and soft and doughy in texture, unless there's a hard nodule that may make us think about cancer. But so when we approach the thyroid, we approach it from the front and then find our way quickly to the back of the thyroid, where the vital structures live, and there are two important ones.
Good. What are those?
The first one is the nerve that goes to the vocal cords. It's called the recurrent laryngeal nerve, and there's one on each side. It goes to each vocal cord and allows us to make speech, and those nerves are paramount to save. If you injure one of those, then you're hoarse afterwards, and that's because one vocal cord doesn't move, and if you injure two, you can have airway compromise and difficulty breathing. So we go to long stretches to save that nerve, and currently I think there's a growing move towards using intraoperative nerve monitoring, which I do, and it's
intraoperative during the surgery, nerve monitoring. Oh, what is that?
So when people go to sleep, we have to put a breathing tube in their throat. And on that breathing tube, we'll have a little electrode sequence that goes through the vocal cords that helps us monitor the EMG, electromyography, the movement of the vocal cord. And we can use a probe while we're in the neck, a little stimulator probe, to map out the nerve, which gives us knowledge of exactly where it is and where we don't need to be and when we're getting close. And it also gives us documentation at the beginning and into the surgery that the nerve is working and that the voice box is intact. And so I use that on every case, and I think most of my colleagues do these days.
And so that helps you stay away from that nerve that can cause the hoarseness, that cause the problem. Is it still, you tell the patient, let me hear you speak, let's see what your voice sounds like?
Yeah, so the
proof's in the pudding?
Yeah, the American Thyroid Association recommends, and again, most of us adhere to this standard, that we examine the voice box before and after surgery. And so in my patients, when they come in at their initial neck evaluation, I'll do a flexible fiber optic laryngoscopy. I'll take a long, skinny fiber optic telescope and look at the voice box and document that both vocal cords move. And then after surgery, the same protocol to document that both vocal cords move and that we've done the patient no harm. Some people have a little hoarseness after surgery because of the breathing tube, and there's some anxiety associated with that, and it's good for them to know that it's just temporary and everything's fine.
Do you ever get in there and you're looking for the parathyroid gland, and you say, where is that thing? Is it hard to find sometimes?
They can be very hard. So the parathyroid glands, just for people who are watching, are 4 little glands that live behind the thyroid. There's an upper and lower on each side, and they're separate and distinct from the thyroid. They produce parathyroid hormone, which helps us regulate calcium, and we actually need 1/2 of one gland to make enough parathyroid hormone. So God's made us with redundancy in our system, so that's good as a surgeon, because if you inadvertently remove one or two, you're still okay. We try to save them, and we know what they look like. They look a little different than the surrounding tissue, but they can be quite small and sometimes hard to see in cases where there's Hashimoto's disease, where there are a lot of inflammatory lymph nodes that are attached to the capsule of the thyroid that look just like a parathyroid. So we go to great measure to save the parathyroid glands as well.
When you remove the abnormal lump, bump, thyroid nodule, what do you do with it? How do you evaluate the structure or what it is, or whether it's malignant or not?
Fortunately, there are smart people who have put together guidelines that we use that are published by the American Thyroid Association, and those guidelines give us direction on, if the mass is this size, then you proceed in this direction, and very commonly we will do an intraoperative pathologic evaluation to determine benign versus malignant, which will guide further surgery in the neck. So
is it a lot different than it was 10 years ago?
it's completely different than it was 10 years ago.
That's what I think is so interesting, the advances that occur to protect the patient and make the outcome become better. So in the back of the thyroid, we're looking to find the recurrent laryngeal nerve, which makes the vocal cords do their job, and the parathyroid hormone, which regulates calcium. So both of those are very, very important. Difficulty in finding those at all?
No, I think experience is the best teacher always in everything, and certainly in medicine in general, as you know. But you begin to learn where the parathyroids live. We know from embryology, the way that we developed, that we can anticipate that it has some certain locations that they like to live in, and so we use anatomic landmarks that we can use, we know are embryologically stable, and to be able to find the parathyroid glands in the neck.
So what are some of the molecular biological advancements that hone in on this stuff for you?
There are many. There are a couple of companies that produce genetic tests, and so when we biopsy a thyroid nodule, we grade it according to a system called the Bethesda category system of the Bethesda Hospital. And if we can categorize people into malignant or probably malignant and benign, and it's the gray zone middle groups that we use the molecular testing on, again, to determine, is this group low risk or is this group high risk? And we're looking at pooled genetic data and microRNA stuff, and we're using oncogene expression now, which is very important in determining how aggressive the tumor might be and whether or not the tumor might be more likely than others to send tumor into the surrounding lymph nodes, guiding us as surgeons towards doing some lymph node dissection at the time of primary surgery, which makes it better in the long term for the patient.
In my simple language, it ain't easy all the time, is it?
Yeah. Well, we just get smarter year by year.
Yeah, and better and better and better. So the recovery time, when somebody has had the surgery and they've had part of the thyroid removed, and you've sent it to pathology and you've got that information, is the recovery time months, weeks, days, hours?
I'll qualify that. So thyroid surgery, fortunately, is not a painful surgery to recover from. Most patients who will have surgery in the morning will notice that by the evening of their operation, very few require pain medication, which is great. So there's not a lot of suffering associated with thyroid surgery. Now, as far as getting back to running marathons, and if you're a triathlete, you probably need to wait a week before you re-enter that kind of vigorous activity.
So when we come back, we'll go a little bit more into the recovery time. And when I see a thyroid surgery scar, sometimes I have to really look hard because it's done so nicely. So we'll be talking about that when we come back. We're talking with Dr. Mark Overholt, board-certified otorhinolaryngologist, ENT physician. We've been talking about lumps and bumps in the midline of the neck where the thyroid gland is. And we've talked about nodules, or we've talked about diffuse swelling. We've talked about a disease called Hashimoto's and Graves' disease, where usually a greater extent of the thyroid gland is involved. Now, Mark, before surgery or during surgery or as you're evaluating the patient, what kind of neck would you rather see? The skinny mini or the one that's all pushed up together?
The long, thin neck is always easier, for sure.
So how difficult is a stubby neck, a neck that's, that's short and the shoulders are up in the neck? And
it provides more challenge, but truthfully, the thyroid gland is so superficial that it's not terribly challenging.
So when a patient has had the surgery and you've closed up the surgical entrance, what do you do to design it to make it where nobody even knows it's been done? Because sometimes I have to search after the surgery to see, oh, that's right, there's where your scar is.
And we've struggled with this forever, and I really think thyroid scars these days are, number one, small. We no longer make the big wide incision that was once kind of classic for thyroid surgery. And I will place them, and my colleagues will, in skin creases that will hide them. There are people who are exploring the avenues of operating to get to the thyroid through different areas, underneath the lip, or in the past we've tried going through the axilla, through the chest walls and the side underneath the armpit, if you will. But for the most part, thyroid incisions are a couple of centimeters wide. They're very small, and they're almost imperceptible over time.
So how do you follow up the patient? You've identified everything, you've removed the thyroid, you've closed it up, patient is talking and it's not hoarse and the calcium levels are good and things are fine. How often do you have to reevaluate looking for return? Does it recur?
It depends on the disease process. So if it's cancer, obviously that's always a possibility, although the 20-year survival for papillary thyroid carcinoma, which accounts for the vast majority of thyroid cancers, is approximately 90%. So survival is excellent in thyroid cancer, which is good news for patients. It's not as scary a diagnosis, and so it's easy to allay their fears up front by giving them just a little pat on the back and saying, you're going to be okay. After surgery, there are some other decisions that need to be made to help for the patient. And one is, do they need additional therapy beyond surgery? So if there was spread to the lymph nodes, if they had an unusually large tumor, if they had evidence that the tumor spread outside of the thyroid into surrounding tissues, and some other features, we might give them a little radioactive iodine tablet to sneak attack and kill microscopic thyroid tissue in the neck. Iodine is the hormone that is the substance that thyroid hormone is made from, and so if the body doesn't have much thyroid tissue and is starved for thyroid hormone, if you give it iodine with a little radioactive tag on it, then that tissue takes up the iodine and it kills the residual tissue in most cases. And so some people will need that. Certainly after thyroid surgery, if you do a whole gland removal, everybody will need thyroid hormone. And you got to have thyroid hormone because the thyroid gland is our metabolic gland. It keeps us going. It keeps the body moving.
Yeah.
And
all parts of the body.
All parts.
So you need it. Is it easy? Is it expensive stuff, the thyroid hormone replacement?
No, thyroid hormone replacement doesn't tend to be expensive, and we're generally very good at getting people dialed into exactly what their body wants. There are some blood tests that we can do that will evaluate, are you getting the right dose or do we need to turn it up and down? And there's some important things that we tell patients who are taking thyroid medication. They're supposed to take it first thing in the morning on an empty stomach with water and then nothing to eat for 45 minutes or drink so that that pill gets absorbed uniformly the same way. Not to have any iron or calcium or multivitamins within several hours of ingesting the thyroid tablet because the thyroid molecule can bind to those calcium or iron or multivitamin and prevent it from being absorbed in the GI system. And so if we teach people the right way to take their pill, we can get them dialed in pretty well.
So the patient has a good chance of living happily ever after, and maybe with a little thyroid hormone and maybe not. And you've allayed their fears if it is cancer, if it's usually papillary. And I had a person tell me one time, a medical person, if you're going to have a cancer, papillary thyroid cancer may be a good one to have because the success rate is so good.
And that colleague also used to tell patients that we shared together that the one thing you can do well, you can do to improve your survival long term, is drive carefully when you come to see me. He had a great sense of humor.
Well, practicing medicine is fun and taking care of people is fun. And Mark, thank you for sharing the thyroid nodules and how careful you have to be, but how good the support mechanisms that you have. And the thyroid gland is, like you said, is the motor. It gives the body muscles. It lets us be active. It lets us be what I call bright-eyed and bushy-tailed, where we got the sparkle in our eyes and we got the energy to do things. So we need that thyroid. We need to take good care of that thyroid and be sure that you have your doctor check the thyroid gland to make sure that he's not feeling anything unusual in that area, and have a happy, happy life.